So thank you so much, Laura, for all your kind words and for the introduction. So I'm a human geneticist. I'm at the Institute of Human Genetics in Hamburg, so in the north of Germany. And maybe you all know that my team has discovered the CASK gene as the disease gene for MICPCH. So that was in 2008. And I really wanted to say that you are doing an amazing job. And I'm really so proud that you come all together and try to make funding available for researchers doing scientific work on CASK. And that is really, for me, it is really so nice to see that you are working together and all these families come together. So really, thank you so much. Okay, so Laura, should I start with the first question or how we should do it?
Yeah, so I'll just ask them. So we've just had more of a broad one, which I think you'll be able to answer. Somebody wrote in and said, what are the consequences of a full CASK gene deletion?
A full CASK gene deletion. Okay, should we differentiate between males and females?
I don't know. The question didn't say, so answer it how you like.
Okay, so I think in a female, so as you know, the CASK gene is on the X chromosome, and females have 2 X chromosomes. And so usually we have one mutation on one X chromosome and the other X chromosome is working well in females. So if we have a full gene deletion of CASK on one of the X chromosomes, I'm relatively sure, and there are no neighboring genes affected or deleted, then you will have the regular phenotype or the phenotype of MICPCH. Does this answer the question?
Yeah, I think so. Yeah, thank you very much. Okay, next one. What do we know about vision and hearing in patients with a CASK disorder?
Okay, so that is also a question which could be answered for males and females. We know more, I think, about the females. So females could have different ophthalmological problems. They could have an optic nerve hypoplasia. So the optic nerve is underdeveloped and may not function properly. So there could be a kind of blindness developing, and that is really an important thing that you check with an ophthalmologist annually, so every year, and also check for the optic nerve. Another problem could be retinopathy. So that is a disease of the retina. This is, at least to me, relatively rare. A more usual things are nystagmus and strabismus. Are you familiar with these terms? Okay, so then that is fine. And we do not have any percentage or how often these ophthalmological findings can occur. So at least to me, I cannot give you any, how common it is or the percentage of females who are affected. That is better for the hearing loss. So for the hearing loss, that is the question about the hearing. There could be hearing loss, and we have a percentage of about 30% in female patients with MICPCH. So checking hearing is also an important thing.
Okay, thank you. Is CASK a neurodegenerative disease? The literature suggests this is not the case, but many parents observe regression in some of their children.
Yeah, so that is really, I would say it's a very important question, and it's a very important, observation. So it is for many genetic diseases that we usually diagnose a genetic disease in a relatively young child. So that means in a child from age 1 to 5 years. And so when we started to find patients with mutations in CASK, then these patients were very young. So we could not say anything of the development in adolescence or what will happen in adults. So, and that is also true for CASK. So actually, I have to say, I do not know what is the phenotype and the development after adolescence. We do not know actually at the moment. So we have to, and I think that would be at least my personal priority for research, that we should have a study in females with MICPCH starting at the age of maybe 12, and then see how the disease is going on until the age of, I don't know, 30 or 40. So I have checked the literature today, and I found one publication which reported a 31-year-old female with MICPCH. And this female had a kind of regression starting after adolescence. But we have to say that she could not speak, so she had no language at all. She could walk until adolescence, and then after adolescence, the parents noted that she was not so she had difficulties to stand, and then later she had difficulties to walk, and after a while she became wheelchair bound. So that means that she had a severe intellectual disability, meaning that language was impaired from the beginning, but she has done better with the motor development, and then later on the motor development, or she had a regression in the motor development. So, and this is something I think we should try to figure out what will happen with your children when they become older. And so actually, I cannot answer this question very well because I do not know. And I have heard from one family in Germany that also this female patient had a kind of regression. I heard it from other parents. I think, Laura, we also had this discussion some time ago. Yeah. But honestly, in the scientific literature, there's only a single report about this female and nothing else. We know from mouse studies from Konrad Mukherjee that there seems to be a kind of regression in the mouse. But for the patients, we really do not know yet. Does this answer the question?
Yeah, thank you. I think it answers it as much as we can at the moment. So yeah, that was a very, very useful answer. Thank you.
Thank you.
What is the prevailing form of epilepsy in patients with CASK? And is the type of epilepsy patient specific?
So here we can also start with the female patients. So the female patients, in female patients, we observe in about 40% of the patients with MICPCH epilepsy or seizures. And there is, at least to me, I think there is no specific type of seizures which occurs in the females. So what we see is various types of seizures, and the onset is between birth and the age of 10 years, approximately, what we know at the moment. And at least to me, I have heard from several families that there is a good treatment for the seizures. So yeah, hopefully if your female child, if your girl has seizures, then I hope it can be treated well. For the males, there is again a wide variety of different seizures, but here we could have a mild form of seizures, But at the very severe end, in the male patients, we can have intractable seizures, which could be, for example, Ohtahara syndrome, West syndrome, or also myoclonic epilepsy. So that are males which have a specific type of mutation in the CASK gene, and they could develop a very severe form of epilepsy, which is also difficult to treat. And honestly, we have to say, if such kind of severe epilepsy is present, then also the developmental progress is quite limited.
Okay, thank you. So why can you get siblings with the same mutation, but with very different phenotypes?
So I think this question is mainly related to brothers, so to male patients, because I think for the females, at least to my knowledge, I think I haven't heard about any siblings. Is that?
Yeah, that we do have some females.
You do have some females?
Yeah, you're quite different.
So females with MICPCH and the same mutation. Is that?
Apparently.
Okay. Okay, so that is a more general question, I would say. So when you have a genetic disorder in your family, it doesn't matter whether it occurs in several generations, in several different people, or only in a single generation and affected 2 or more siblings, then they have the same mutation. But the phenotype is variable. So that is what we usually see in genetic disorders, that is not the same in every person. So, I mean, we have the mutation in a single gene, and that is the main reason why these people are affected and have a disorder. But the disorder can range from relatively mild to more severe in the same family. And this is very difficult to explain why we see different or a variety of phenotypes, but at least as a human geneticist, we explain it in that way that of course we have the main genetic problem or defect, but of course we have also other genes in our genome and variation in our genome which somehow modify the phenotype, and also environmental factors are also somehow modifying a phenotype. So that is somehow, yeah, a usual explanation for genetic disorders and the phenotypic variability what we see.
Thank you. Thank you very much. Is severe speech apraxia common in children with CASK?
I think so.
Can you explain what speech apraxia is for all of us? Do you know?
I think I will give this question to Dr. Amin.
Oh, okay. We'll leave that one for now. I'll put a star by it. Okay. Is it possible to get tested for skewing of the X chromosome? And is there any evidence that this is the cause of some of the more extreme phenotypes?
So a more severe phenotype, or?
I guess either, like any of the extremes, I'm presuming.
Okay. I'm not sure what about this. What about the situation in the UK or in the United States about the X inactivation studies? So I cannot say anything about it. I mean, yes, in principle you could do it, but I mean the result, whether there is a skewing or not skewing, and whether X inactivation is random. I mean, there is a result, of course, but based on the result, you cannot predict the outcome of the phenotype. So we had the question: what about a gene deletion, and what about the phenotype of a patient with a gene deletion? So we have several examples where we have a deletion of CASK, but also of neighboring genes. And when we have a very large deletion on the X chromosome, including CASK and several other genes, then we see that we have a skewed X inactivation in the blood cells. That is what we can investigate in blood DNA. And there are several cases with such large deletions, and the phenotype is relatively mild. So Laura, we are discussing about this girl from Argentina, I think, right?
Yeah, South America, yeah.
And so there is a possible explanation why some females have a relatively mild phenotype. Then we could see the skewed X inactivation, but I think that is not for all females.
Okay, yeah, so it's quite rare. So in a way, you're saying that if the deletion is even larger, then actually it can sometimes cause milder phenotypes, even when it's taking out multiple genes, which is kind of seems to be the opposite of what you'd expect, but it makes sense because is the cell somehow, the chromosomes like being identified as that is faulty and it's not expressing that one because it's just too faulty and it's expressing the one without the missing genes. Is that what's happening?
So that is a very good question, and you have the right answer. That is biology. I mean, if you have a cell which expresses the X chromosome with a very large deletion, then the cell will die. The cell is not able to survive. And that means that only cells with a normal CASK gene will survive, and then you have a skewed X inactivation.
Okay, thank you.
That is just biology. That is a kind of selection against the large deletion. What we do not have when we do not have the situation when only the CASK gene is affected, either by a deletion or by a single point mutation, then we do not have skewing of the X chromosome inactivation. We have it only when we have deletion of CASK together with multiple neighboring genes. That is a bit strange, I know, but that is biology because the cells are dying then.
Thank you. I think you explained that really nicely. And the last one, which you might not be, well, you'll probably be able to only answer for what happens in Germany, but is it possible to test for a CASK mutation in the womb? So obviously a parent's already got one child with a CASK disorder and they're pregnant. What options are there to see if their second child might also have the same mutation?
So that is, I mean, in Germany, this would be possible by regular prenatal testing, genetic testing. So we in Germany could do this as on a regular basis.
Okay, but would that be like by amniocentesis?
Amniocentesis, or what is the English name?
CVS?
Yes, CVS.
Okay.
Yes. What is the English name?
Oh, there we go. Kate.
Yes.
Thank you, Kate.
Thank you.
Common.
Yes.
Yeah,
so
just
that is earlier in the pregnancy. You can do it between 11th and 14th weeks of pregnancy, and the other testing is later.
Okay, what's the test called where they can find the, well, yeah, so I had, just from my personal experience to answer this question, but I'm not sure what it's actually called. It might be one of the two that you're talking about. They just took my blood and tested that for fetal DNA that was in the blood, and that was very early as well. That was like 9 or 10 weeks. Is that the... Oh, okay. Oh, yes. So Kate is also, just to tell everybody who Dr. Baker is, so Kate is also a clinical geneticist. I should have had her unmuted. So, and she's based in the UK. So that's why she's able to answer all these. Thank you. Thank you, Kate. If I could find you, I'd unmute you. But every country is different, isn't it? And they will, I guess, be able to offer different things. So
I don't know. We offer CVS and also amniotic fluid testing.
Okay. Okay. Well, actually, that's all the questions now, Professor Kutsche. So thank you so much. You'll be able to get to your bed now, which I'm sure you're desperate for. And we were actually going to go on to Dr. Baker now and Jessica Martin about the bingo study. So I think it was just Jessica that was going to speak, but if I can find Kate, I could unmute her so she could just answer. It's hard to find it. Oh, here you are. Kate, I'll just, if you don't mind, I'll just allow your mic. And if you just want to say a quick bit about the kind of, because I know, because this question comes up a lot on our Facebook group, so I know people want to know about the early testing for CASK or any genetic mutation.
Thanks, Laura, and thanks, Kirsten. It's lovely to be here. The only, answer I've already put in the chat is it is a really individual situation for each couple to know what prenatal options are going to be open to them, because it may depend upon not just where you live, but the type of CASK variant that your child has, whether it's de novo, whether it's inherited from a parent. So I'm wary about sort of saying this technology might be available to everybody. I think if you're not clear about what prenatal options might be available to you as a parent or to parents who you're supporting in the community, I would just really encourage people to get back in touch with either the neurologist or the clinical geneticist who fed back the original CASK gene variant or mutation report to you as a couple or to you as a parent, and just re-ask the question about what is the recurrence risk if I go on to have further children, and what are my prenatal testing options, because the technology is moving on all the time, but it is very variant specific and family specific in terms of what's available, if that makes sense. The non-invasive testing that Laura's talking about was based upon testing what's called free fetal DNA. So that's tiny amounts of DNA that cross over the placenta from a developing baby to a mother's blood circulation. And that can sometimes be tested for gene variants, but it's not a straightforward process, and it's not available to everybody for a whole lot of different reasons.
And we're going to go back to we're going to start over with epilepsy questions. So this is probably going to be Sam's remit. So I'm going to spotlight Sam, not to put pressure on anybody.
I feel pressurized now.
And okay, so right, we only have about just over half an hour. So what treatments are there for myoclonic seizures, and are you aware of anything being developed like a gene therapy? I think they're thinking for myoclonic seizures.
So no, but as you know, myoclonic seizures can happen due to various reasons. So someone can have epilepsy due to a genetic condition, they can have myoclonic seizures. You can have biochemical problems, metabolic disorders, then you can develop myoclonic seizures. You can have cerebral palsy, brain damage due to lack of oxygen, or brain trauma due to infection, due to car accident. You can have epilepsy and myoclonic seizures. So myoclonic seizure is description as seizure type rather than condition. And when we treat seizure types, it's important we consider the cause rather than the seizure type. Because if we have targeted treatment, we'll have to think about how we treat the cause rather than the symptoms. So no, we don't have specific treatment for myoclonic seizures, but a lot of people with epilepsy due to CASK or due to other epilepsy syndromes can have myoclonic seizures.
Thank you. A second question, are brief myoclonic seizures harmful to the brain? Can they be?
Yeah, that's interesting. We Well, I guess it depends. If you don't have any seizures at all, then obviously that is good news. But if your brain is busy and constantly firing abnormal electrical activity, then that is not good. Okay? So yes, it may not cause brain damage directly, but it will impair other activities. For example, if you have constant seizures, even if they are small, that will impair your learning, okay? That affects your cognition, that affects your behavior, and affects other activities. So having too many seizures are not good, even if the seizures are short. But obviously, if you have prolonged seizures, you may know generalized tonic-clonic seizures for more than 25 or 30 minutes, then that is very bad for your brain, compared with little seizures, i.e. short myoclonic seizures. So yeah, if you have short myoclonic seizures, it's not as bad as if you have some prolonged seizures. But it's about balance, isn't it? Because if you expose someone to too many drugs, then that is not good. And unfortunately, sometimes you have to use 2-3 drugs to control some of these little seizures. And these little seizures can still happen. And you have to decide, do I really want to expose myself or my child to too many drugs in order to stop these little seizures? And sometimes we may have to say, I think it's probably better to have the little seizures rather than exposing someone to too many drugs. Because polypharmacy, when we use 2-3 drugs together, is not a good idea. It causes a lot of problems. So I think we should always try and avoid using too many drugs, because they interact, they affect your learning, they affect your behavior, and they can cause other side effects.
Thank you. So just for maybe parents who don't have children with seizures, so the main ones that families seem to mention are myoclonic and epileptic spasms. And Sam knows this, and quite often they show videos of their children having either a myoclonic seizure or an epileptic spasm, and they look absolutely identical. So that is where this question comes in. So how do you differentiate between myoclonic seizures and epileptic spasms? Is it differences in an EEG, and should they be being treated differently if they've been given a different name?
Yeah, so they are treated differently and they can present at different stages. So infantile spasms, generally people present or have spasms during infancy. And for that reason, we call it infantile spasm or epileptic spasms. But they can happen at any stage, but it's very rare. Generally, they happen during the first year of life. And quite often, when people have a genetic disorder causing epilepsy, they present with epileptic spasms or infantile spasms in the first few months of life. And the way we treat that is different. We use different treatment for infantile or epileptic spasms. Generally, in the UK, we use steroids for all individuals with epileptic spasms, apart from tuberous sclerosis complex, where you use vigabatrin. Sometimes in some centers, people use both drugs together, infantile for steroids and vigabatrin during infancy. But if you develop epileptic spasms during childhood or adulthood, you can still use steroids and you can still use vigabatrin, and we use it sometimes. But as I said, I think epileptic spasm is very rare in older children.
Okay, thank you. Yeah, I think, well, hopefully we're getting some epilepsy studies started in CASK, because I think some parents will maybe feel that their children did get epileptic spasms later on. So maybe we are this unusual cohort, but we need to find that out, don't we?
And your question about how to differentiate, so well, I think it can be difficult sometimes to differentiate some of these seizure types. I think if you have typical infantile or epileptic spasms, you should be able to, well, clinicians and healthcare professionals who are trained, have expertise in the area, should be able to recognize epileptic spasms. And we always advise parents to be very vigilant and to monitor for epileptic spasms during infancy, because we want to be prompt with treatment. We want to treat epileptic spasms as soon as possible. Because, you know, we've done study, we've looked at this previously. We know if we treat epileptic spasms quickly, then you are likely to have better neurodevelopmental outcome. If you delay treating epileptic spasms, then you are likely to have poorer neurodevelopmental outcome. So it's really important to make sure that we recognize, we diagnose epileptic spasms very promptly and give them treatment very promptly. For us, yes, we can clinically differentiate between myoclonic seizures and epileptic spasms. Myoclonic seizures is quite rapid, whereas spasms are slower flexor spasms. Yeah. And also you can do EEG. Yes, EEG can also help you if you are unsure. But generally, clinically, I think most of us should be able to differentiate between myoclonic spasms or epileptic spasms.
Okay, thank you very much. You've also answered the next question, so I'll go on to, so somebody's asking, why does the ketogenic diet often work for a short time, but then the effects decline?
Yeah, so I think ketogenic diet is a good option. I always recommend that, especially for young children, because it's very easy to implement and kids get used to it very easily. You and I may struggle to change our diet and get used to something new, whereas for children it's much easier. And it's available. And when kids are really young, you can use special milk formulation. Some of you may have expertise in ketogenic diet. You may have had your children on the diet, but it can also be effective, and it's not etiology specific. So it's not just good for CASK. It's not just good for cerebral palsy. It can work for all types of epilepsy, all types of seizures, and it doesn't cause significant side effects. So the way we use, generally, we use the diet for 2 years. We worry about long-term safety. But I always say, if it's effective, you don't have to stop after 2 years. You can continue using it. And no doubt, there are a lot of people who have been on the diet for more than 2 years. So I think in terms of tolerance, I think it's probably better than conventional anti-seizure medications. You know, quite often you have this honeymoon period with other anti-seizure medication. You use it for 2 weeks, it works really well, and then it wears off. Whereas with the diet, it's not quite like that. I think it stays effective for most people, as far as I'm aware. But maybe in your experience, you've realized that the diet didn't last long, but generally it should last long, or longer than when you compare it with anti-seizure medications.
Okay, thank you. Right, so just quickly, I'm not sure if you're going to be able to answer these. I don't know how much you know about this, but recently in the BBC, they mentioned a neurostimulator for deep brain stimulation. And so somebody's asked a question on that. And it sends like electrical signals deep into the brain. This is a boy was presented, and his daytime seizures reduced by 80%. Anyway, if you do know about this, what type of epilepsy would this work for, theoretically? Obviously, it's really, I presume it's very new. Would it help dystonia too, potentially? So yeah, that's the question.
Come on, Laura, I know everything. So DBS, yes, so interesting. So DBS, so we have a DBS service in Bristol. In fact, I'm leading the service, deep brain stimulation for dystonia. So if you don't know what dystonia is abnormal movements. Maybe you have experienced dystonia, maybe you know. When you move your arms, for example, you want to move your arms, you've got muscle group there, pulls your arm, you've got another muscle group there, pushes your arm, yeah? You and I can do that easily because we've got system controls between our muscle groups, yeah? Because you can do that. And there is a part in the brain called basal ganglia, and that part in the brain controls this coordination between the two muscle groups. If for some reason your basal ganglia is not working because you have a genetic problem, because you had brain damage and so on, that system becomes a bit disoriented and the control doesn't work. Instead of moving your arms in a controlled fashion, you'll be moving your arms like in this way. And that is dystonia. What we do for dystonia, then we have this device called deep brain stimulation. We stimulate the basal ganglia. And for some reason, when you stimulate the basal ganglia, that can improve the way you move your hands, and it can improve the function of the basal ganglia. So that has become an established treatment in the UK. There are 3 DBS centers for dystonia: Bristol, Liverpool, and London. At the moment, we're doing for dystonia. But in recent years, we've been thinking about using DBS for people with epilepsy. So there have been some small pilot study in the US showing that if you use deep brain stimulation, it can be effective for epilepsy. So one of my colleagues, Will Singleton, and I are planning to set up a national study using deep brain stimulation in the UK. We are hoping to apply for an NIHR grant to see whether we can do this study using the same device, but for children with epilepsy. But instead of stimulating basal ganglia, we will be stimulating somewhere else in the brain called thalamus, which is not far from the basal ganglia, is next door to basal ganglia. And we think if we stimulate thalamus, we may be able to disrupt this excessive firing activity in the brain, which causes seizures. Because if you have seizure activity there, that can go to your thalamus because it's all connected. But if you've got some stimulation disrupting that network of excessive activity, then you may be able to control the seizure activity. So that is our plan, to set up a study, and it's not going to be just for one specific epilepsy syndrome. We will be recruiting people from with any epilepsy syndromes, as long as their epilepsy is refractory, i.e. if they've tried 2 anti-seizure medications and if they still have seizures, then they can take part in the study. So people with CASK, if they have difficult epilepsy, then they will be able to take part in the study.
Thank you, Sam. I didn't know about that. That sounds really, really interesting. I really hope you get the funding for that.
Well,
it gives a lot of families.
Yes, it's going to be very expensive trial to run, because as you can imagine, these interventional studies are very expensive. But we think it's really exciting, and hopefully NIHR will be supportive. But we'll see.
Yeah. I'm sure. I can't see why they wouldn't be, but yeah, fingers crossed. I think, sadly, we've got to stop all the epilepsy questions there, because we're going to run out of time to ask other ones. If we have time at the end, I will ask them. But that was the main ones that were asked in advance. There's a few general neurological questions, and one's on neuropathic pain, which I have had some families contact me recently, so I do want to ask this. What are the drugs usually used to treat neuropathic pain? They're asking specifically for CASK patients, but I know we don't know that. So for patients living with brain malformations, have you ever heard about, and it's kind of a separate question, I think, child migraine or digestive origin? Yeah. And then they ask about a drug called amitriptyline. Yeah. Is that something that might be useful in this case?
Yeah, so neuropathic pain, again, interesting. Thanks for asking this. So it's not uncommon. Unfortunately, a lot of people suffer from neuropathic pain. Whether you have CASK or other condition, you can still have neuropathic pain. And the most commonly used treatment or drug for neuropathic pain is gabapentin. And I really like using gabapentin, because with gabapentin, you can treat at least 2-3 things, okay? So it works really well for neuropathic pain. It works really well for dystonia, and it works for epilepsy as well. If you have someone like a person with cerebral palsy, they are likely to have neuropathic pain, they are likely to have dystonia, they are likely to have seizures as well. And if you give them gabapentin, that is very good, because you can really treat 3-4 things with one drug. So I prefer using gabapentin. Generally, we use that. We also use amitriptyline for neuropathic pain, sometimes for depression and anxiety disorders, but gabapentin is my preferred option, and it's better tolerated, and it doesn't cause significant side effects.
Thank you. And just one very last question on epilepsy, because they're coming through, about VNSs. So can a VNS help with something that has been diagnosed as epileptic spasms? Is that an option for that seizure type?
So in terms of VNS, I think everybody, if you fail 2 anti-seizure medications, you should be considered for epilepsy surgery program, i.e. VNS. And generally, VNS is effective for all types of seizures. If you have epileptic spasms, as I said, there are different interventions. We use steroids and vigabatrin rather than vagal nerve stimulation. So if you've already failed 2 drugs, then you should really be considered for VNS. VNS is well tolerated, it's safe, it doesn't cause any side effects, and it's available in most places.
Thank you. Yeah, we have a lot of families diagnosed with epileptic spasms who have definitely tried at least 2 different drugs, ourselves included. So yeah, that's a great answer because I didn't know that about VNS. Okay, we'll go on to sleep quickly, and then we'll go over to Dr Tuffrey. He's going to answer our general paediatrician type questions. So, but Dr Amin, you have written a guidelines for CDKL5 and sleep. So hopefully you can answer some of these. So my daughter is on clonidine for sleep, but it isn't really working. What are the pros and cons of the next drug or another drug?
Is it Catherine's turn or my turn?
Well, Catherine could answer that actually, but I've got your name over the top.
Okay,
You can
yeah,
give
so
your
yeah, I
opinion,
will. Yeah,
and
yeah, so
Catherine
I
could-
will. Sorry, yes.
Yeah.
So clonidine, you know, there are a lot of options one can try, and I'm sure you've probably tried all the sleep hygiene options and non-pharmacological interventions one should try because they are safe and they can be effective. But I guess if you've already tried those, then you'll be thinking about medications. As you know, melatonin is probably the most the safest drug for sleep. It's a good sleep inducer, but again, it may not work for all children. Then you will have to think about other drugs, and you've already now started clonidine. We just need to make sure that you are using the right dose, because with clonidine you can sometimes go and use a higher dose. Obviously, it can cause blood pressure problems and can make you very sleepy, but some people have better tolerance, so you can use a higher dose. And if you've already explored that and you've used a high dose and you've got nowhere to go, then you may need to think about other drugs. For example, gabapentin, I mentioned earlier, neuropathic pain, dystonia, epilepsy, and also can be helpful for sleep as well. You can use a higher dose in the evening, and it doesn't really cause significant side effects at all. So that's another good drug. There are other drugs one can use, chloral hydrate, for example. You don't want to use it too regularly because you may get to rely on it and it can be quite sedative. So that's that. And promethazine, antihistamine drugs are available also that can also be used. So there are different options one can consider. But it's important to know if there is a trigger, if there is a cause for the poor sleep. And obviously working on those triggers can be very helpful. For example, if they have pain in their hips, musculoskeletal pain or gastric pain and something like that, rather than just treating the symptom, and sometimes it's helpful to treat the cause as well.
Okay, thank you. I think that actually brings us on to the very next question, which is quite a few of our children at the moment are waking up screaming or crying in the middle of the night for around at least an hour. Obviously, it's really hard for us to know what on earth is going on. I think some of us think it might be gas, bloating, maybe hip pain, like all the things you've literally just said. So just repeat. So if it, and that's obviously disrupting their sleep. So are you saying maybe gabapentin might be worth a try? This is a regular occurrence.
I think they really need to have a full MOT. I don't know what the MOT phrase is in Europe, if they have this such thing, MOT, when you do full assessment from top to toe. Basically, you want to make sure that there is no trigger. For example, you look at the teeth, make sure that there is no dental problem, because quite often that can cause pain, that can cause sleep, poor sleep. And unfortunately, some of our kids are unable to communicate. So we need to make sure that we look for all these issues specifically. So pain, dental is important. Musculoskeletal complications and pain, again, that needs to be addressed and monitored for. Bowel complications, as you say, air swallowing, and sometimes we see gut dystonia in some of these children with neurological disorders. So their bowels become really spasmodic, they get stiff, and that causes a lot of pain. So that can be problematic as well. And constipation, obviously, that's important. Urinary tract infection can cause pain at night. and epilepsy, we need to make sure that they don't have seizures in sleep, because, you know, some people can have continuous seizure activity in sleep. And if you have that, you'll have very poor sleep, and that affects your behavior during the day and so on. So we just need to make sure that we've looked at all these triggers and treat them promptly.
Okay, thank you very much. Right, we'll go on to Dr Tuffrey now, who I'm just going to spotlight if she's there. Hopefully. Are you there, Catherine? Yes. And I'll just...
I am here.
Thank you, Sam. Hi, Catherine.
Hi.
So Dr Tuffrey is a paediatrician with a lot of experience in dealing with children with neurological disorders, and she has experience with a few CASK patients as well. So we've got 15 minutes, so I'm going to plod on. So the first question's about reflux. You might, I don't know if you're going to know this off the top of your head. Somebody's asking for a recommended dose of anti-reflux drugs. Yeah, can you, I mean, obviously we don't know the size of their child, but I guess is there like a maximum us in the UK kind of would go to?
So UK doctors, we usually use the British National Formulary for children, and I was always looking that and see what the recommendations are. I think it's another question that's related a little bit to what we've already been talking about, which is knowing what you're treating, really. And I think one of the real challenges for parents of children with CASK or any number of other neurodevelopmental, neurodisabling conditions is that sometimes children have symptoms that's really hard to, symptoms and signs that are really hard to work out what's the underlying problem. And I think it's very easy to throw medicines at the problem, whatever that is, whether it's sleep or screaming in the night or whatever. But sometimes we can cause more problems than we solve. And I think it's important to know what you're treating first. So what I would say about reflux is it's important, first of all, to decide really whether it is reflux. And sometimes it's really hard to know because some of our kids can't tell us exactly why they're unhappy. And so sometimes we do have to just guess and have a trial of treatment, but I think it's important that we do what we do with any children, which is use the drugs as recommended in terms of trying things like Gaviscon first to see if that will help, and if not, moving on to things like omeprazole, which I think the question may have been about. And we would use an appropriate dose, and it wouldn't be any different for a child with a CASK mutation as opposed to any other problem. But the other thing I would say is we should always review medication. And one of the things that I find quite a lot with my neurodisabled patients is that they end up on drugs for years and years and years without anyone actually re-looking and saying, do they still need this? Maybe they never needed it in the past, but it was trialed because the child was shouting in the night or whatever, and just making sure that children still need what we've got them on, because otherwise they end up accumulating lots and lots of treatments which may or may not be being helpful. But I would treat it with the same dose that I would treat any child who's got reflux, as long as I'm pretty sure that's what I'm treating, and then have a trial off medicine and see, 6 months down the line, see if they still need it, see if the symptoms recur or not.
Okay, thank you. The next question is about bowel pain. So first one is why does it appear so common in children with CASK disorders? And also, what can we do about it to alleviate it?
So bowel pain related to constipation, are we thinking, or related to anything?
I think a bit of both. So either like accumulation of gases or constipation.
So I think, again, these things are multifactorial. I think children who have brains that aren't doing what other people's brains are doing can have problems with the nerve supply to the guts and how the brain communicates with the gut. Remember, our brains communicate with all parts of our bodies, and they communicate with our guts. And so children with all kinds of problems, cerebral palsy, but other genetic conditions, often have problems with slow guts, which can lead to constipation. They're more likely to have reflux. They're often, if they're not ambulant, they may not be upright, and we know being upright just helps things like constipation and reflux, because that's sort of what we're designed to do. So a bit of being in a standing frame, one of the main uses, I think, really, of putting kids in standing frames is to help their constipation. Actually, I'm not sure it does very much for their hips, but it certainly can help their constipation. So I think position, diet, you know, kids on formula feed only may have different bowel habits from kids who are eating actual food. Position and the way the brain is, you know, talking to the gut, if you like, can lead to problems. And sometimes, again, it's a child seems to be in some distress and we're guessing it's their tummy pain, but can be difficult. Air swallowing, as Sam said, gut dystonia, relatively rare, but we do see it. All of these things, and this is the challenge for dealing particularly with the more profoundly disabled young people, is trying to work out what is causing what.
Thank you. Yeah, I think we all know the feeling. So next question is, what recommendations do you have for maintaining motor skills in CASK patients, and I don't know, and or to combat early osteoporosis? This came from a parent with an adult child. Yeah,
so I think, again, it's nothing specific to CASK mutation, people with CASK mutations. Any sort of motor skills, both developing them and maintaining them, just as with normally developing children and adults, needs practice. So you just need to have activities and opportunities to move in different ways, to develop skills, but also to maintain them. I know there's been questions about regression, Laura, and that's a sort of different question. But I think in general, it's keeping active the same as it is for everyone. And that's more difficult as you get older. We know that normally developing teenagers get more sedentary, and it can be difficult to keep them moving. The other question was, there was a related question. What was the second part of the question?
About osteoporosis. Is there a way to kind of help?
So again, weight bearing if possible, but not all our children are capable of weight bearing. There has been some research with cerebral palsy looking at standing people on vibrating platforms and things to try and increase bone density. But I think it's tricky if you're non-ambulant and not able to weight bear. It is very difficult. Making sure everyone's got enough vitamin D in them. So supplementing our kids is always important, and making sure that their diet's got enough calcium in it. But those are the things we can do. But otherwise it's difficult. And then children who are ambulant, is at least to a degree, is keeping them ambulant, keeping them active, will increase their bone density or maintain their bone density. But as I say, can be very difficult with young people who are not able to weight bear.
Do you suggest, do you think that lots of our young people might not be getting as much sun as like a normal child? Because I suddenly thought about it, because Sarah's just been given vitamin D. I thought she's not outside half as much as my 4-year-old. So I guess that could be contributing, and maybe it's something we need to just bear in mind.
Yeah, so I try and advise all my families about this. So there's several things. Firstly, kids may not be able to just run in and out of the house and be outside, take themselves outside. They've got to be physically taken outside potentially. People worry about youngsters staying warm if they're not ambulant. They're just sitting in a chair, so they're more likely to have more clothing on. And of course, then there's the slightly confusing public health messages about suntan lotion, isn't there? So it's a sort of, a lot of the schools do this. No one's allowed to venture outside without factor 50 plastered all over them. Actually, what we should all be doing is going out for 10 minutes to get a bit of sun exposure and then putting suntan lotion on. But obviously that's a slightly more complex and nuanced public health message. So the public health message tends to be, don't go anywhere without suntan lotion. But I would say for our kids, get them out for 10 minutes, quarter of an hour without long sleeves on, etc. when it's nice weather. But the other thing is, before you put the suntan lotion on, but the other thing, of course, is in this country, none of us get enough vitamin D over the winter. So we probably all should be on vitamin D supplementation over the winter. Certainly us perimenopausal women should be, and our kids all should be as well. And it won't hurt for all the kids to be on vitamin D supplementation all year anyway, to make sure they're getting enough.
Oh, thank you. That's really useful to know, actually. So you're running out of time a little bit. So I don't know if you can answer this. This again is from a a parent of an older child, what gynecological checkups do you recommend? So this is for an adult. I know you're a paediatrician. Type, frequency to detect abnormalities. I don't know if you can answer that.
So the main thing is that there's normal screening for every woman. So smear tests, and people who've got learning disability should still be eligible for smear tests and should still have HPV vaccination to prevent cervical cancer. And I recommend that all my young people have HPV vaccination, because it can be very challenging if you've got learning difficulties to undertake smear tests, and that can be tricky. There's tricky for GPs sometimes to actually have access to hoists to get people onto couches and things, which is a general problem in terms of providing adequate healthcare. Yeah, so smear tests might be appropriate. If somebody's got severe learning disability and is fully supervised, then there's probably isn't anything particular that they need, and unless they've got symptoms, in which case obviously those symptoms need investigating. But I wouldn't recommend any other routine checks any more than any other woman should have routine checks if they're healthy.
Okay, thank you. What solutions do you suggest for hydrating patients with serious swallowing problems, but avoiding jelly drinks that are too rich in sugar?
So this for kids who are not very good at
yeah, again, I think
fluid.
this is for an adult, and obviously they don't have a feeding tube. Yeah.
So it's not an uncommon. I mean, it's not uncommon in children. We have lots of children who don't like drinking, actually. Children with typical and not non-typical development, who can be a bit resistant to drinking. So it's about getting food that's got plenty of fluid in it, you know, fruit and veg and that sort of thing. Obviously, if you've got a problem swallowing thin fluids, then you might need a thickener. And then if you don't want to put too much sugar in, then I agree, then, you know, soups, things like that, which are thicker. We often do recommend things like jelly, ice cream, things like that for kids, because they are quite often like that, and you can get a bit of fluid in. You can get sugar-free jelly. It tastes a bit disgusting, but they might not mind. So yeah, and then ice lollies, if you're able to drink thin fluids but you're a bit resistant to drinking drink. And you can make your own ice lollies at home potentially with not too much sugar in. So I think it's about being creative and thinking what is in stuff. Yogurt, some kids will take loads of yogurt when they won't drink. So it's trial and error really, but ultimately if somebody's really not getting enough hydration, then it might be necessary to look at a gastrostomy, I guess.
Okay, thank you. They're all really good ideas. And then last question. This was something that came up on the chat today, actually, which has come up in the past, but nobody had asked a specific question. But is it normal for children with disorders like CASK to not sweat?
I mean, children don't sweat in quite the same way as adults do anyway, and or it's not as noticeable, partly because it doesn't smell. I'm not aware of any particular issues with sweating and CASK mutation, unless Sam knows anything. He's gone off, taking his camera off, but I don't know if he's got any.
No, I don't think so. You know, there are some certain conditions where you can't sweat, you have problems with the sweat glands, but I don't think that is the case with CASK. I think just because they are not physically active, maybe that's why they don't sweat.
Yeah. Oh, Christy's got. Yeah, I mean, I also wondered if it's just because most of our children are young, and like you said, I don't actually notice my 4-year-old sweating either. Let me just see if I can get Christy. Oh, Christy, can you put your question in the chat, please? That was the last question.
I'm not able to type in the chat for some reason.
Oh, go on. We can hear you. Go on, speak.
No, I just wanted to say that my daughter's neurologist says that topiramate impedes the ability for a person to sweat. So if children are on that for seizure treatment, that could be a reason.
Oh, so topiramate, so the epilepsy medicine?
Yes. Mm-hmm.
You come across that, Sam?
No, I haven't come across it. Obviously affects your acidity level. Topiramate is known to make you acidic. So maybe that the way, because of that, it makes you, affects your kidney function and your acid level. Whereas, yeah. But yeah, we use it quite often. There are a lot of people on topiramate. It's commonly used drug. But it's very hard to know because most of our kids don't complain of this issue, so it's difficult to know. The commonest side effect of topiramate is loss of appetite and loss of speech. So that's the commonly seen, but I've never come across sweating issues due to topiramate.
Okay, thank you. A quick one. Kate's saying temperature regulation is being discussed quite a lot across other genetic conditions at the moment, either overreacting or underreacting to environmental change. Yeah, often in excess. I think we can definitely relate to that, Kate, in the CASK community. I'm not sure if there's anything published, but I was always led to believe that this is because of the small ponds which regulates temperature. Is that right? And so it's to potentially be expected that we might, that our children might not be able to regulate temperature. Does that sound right?
Yeah, I think it's, hypothalamus is your thermostat, and it's fair to say that most children with neurological disorders have difficulties with regulating their thermostat, and they will have high temperature, low temperature, high blood pulse rate, low blood pulse rate. So they have these changes there in their autonomic function. Is commonly seen. So I suspect CAS gene is also expressed in these areas in the brain, which controls temperature, the thermostat area. So it's possible, yes. I think it's commonly seen in people with neurological disorders.
Yeah. Okay. Yeah, I think it probably has never been measured necessarily in the population. So that might be something for future studies. Okay, so thank you very much, our expert panel. That was amazing. I think everybody's got a lot from that. And we're perfectly timed. Now we're going to go over to Carmen.